we know that these are factors that increase your possibility of having an intracerebral bleed. I did mention this morning, and I don't have the data, but I will get it. I've got to research it a little bit more, that I was told by someone else, and I hate this, but that in Tennessee we have a high instance of intracerebral bleeds related to high blood pressure. And I could imagine how that would be true, because we do have a lot of patients with high blood pressure. But other things, too, is like anticoagulant therapy, that and subarachnoid hemorrhage and ABM. But what we're going to talk about right now is intracerebral. We'll separate these out and do this separate. So, again, without going into it, we talked about ischemia, not getting enough blood flow. We have a cascade of events that that worsens the outcome. Here, blood itself worsens the outcome. Neurotoxicity from the blood, just the developing and increased pressure in the brain, that also the hematoma, displacing tissue, herniation, all these things have to do, can occur with intracerebral bleed. So the mortality is high with an intracerebral bleed. And most of it occurs in the more common sites or in the deeper structures of the brain, the putamen, the thalamus, the pons, and the cerebellum is where you see a lot of intracerebral bleed. Now, again, intracerebral bleed is equivalent to increased intracranial pressure. So when you're looking at intracerebral bleed, one of your leading things is decreased level of consciousness. Now, with an ischemic stroke, you're more likely to see a focal symptom, okay? Paralysis, dysarthria, those sort of things. Here you're going to have a decreased level of consciousness, coma. Severe headache would probably be more likely with a subarachnoid hemorrhage. But this is where your blood pressure really, these patients come through the door, their blood pressure will be totally out of control. But these are also, vomiting is an issue, okay? And if you see them come in on the stretcher, a lot of times they've already got something there for them to vomit in. They've had so much emesis. Now, high rate of early neuro deterioration. So here you have an early hematoma, and you can just see how it expands. This is at 2.5 hours, or 20, is that 25? 2.5, and this is 6.5 hours, just from here to here. So they're going to come to you in ICU, and this is why it's so important to monitor these people, anybody with any kind of bleed, for deterioration, and you can understand why there. The hematoma expansion is used to predict the clinical deterioration. So we can see here what is going on. Now, how do we do it with the CT? Pretty much is our main, and then you can use CT with contrast, but this right here, actually just a regular CT, was what we were seeing right here to determine the hematoma growth and expansion. Now, with our comprehensive status here in taking care of strokes, one of the things you have to do is to be able to take care of these patients with intracerebral bleeds. Not only ischemic stroke, but you also have to take care of the intercerebral hemorrhage. And so we are required to write down an IC8 stroke score. And our radiologist can do this, or our neurologists, okay? Now, are the nurse practitioners, are y'all doing this now? They want you to do it, I'm sure, don't they? Everything will move on to y'all. So what they do is they get the Glasgow, the age, where it's located. Is it in the pons? Is it in the medulla, in the cerebellum? That would be infratentorial. So they get 1 point, because that means if it's in that area, it's a worse type of bleed. And then the volume, they look at their CT and they can actually see the volume. So anything greater than 30 is considered to be a high risk for deterioration, so they get a 1. If they have blood in the ventricles, they get a 1. So when they did studies on this, they found that people that had a 5 and 6 usually died, okay, when they get 5 or 6 points there. And this has to be documented on the patient's record. Now, just basically, just here we have a brain. It's 80% tissue. You have a certain amount of blood. The rest is blood and cerebral spinal fluid. Actually, the way we handle increased pressure is probably related to cerebral spinal fluid more than it is actually blood flow to the brain. But here you have a hematoma form, and now you have increased absorption of cerebral spinal fluid, and through the automaticity of blood, how it's sensed and sent to the brain, then actually it shows here a little bit decreased also amount of blood flow to the brain. Probably this is going to be more cerebral spinal fluid and a little bit less as far as the compensatory mechanism. Nevertheless, for a short period, this patient will have a normal intercerebral pressure because of the compensation. And then all of a sudden it start going up, up, up. Here we have a patient that we have a ICP in. We're monitoring their intracranial pressure. And the big thing we look for is cerebral perfusion. How well are they being perfused? Because oxygen, cerebral perfusion means oxygen to the brain. It means glucose for nutrients, etc. So the way it is calculated is you take the mean arterial pressure, which is here is your, this right here is your formula, but all this is done with a monitor because I have an art line in. And you got the mean arterial pressure, it comes up as 90. The ICP is 20, so you subtract the ICP from this and you get 70. That's a good cerebral perfusion. So even if the blood pressure is a little higher and the ICP is a little higher, as long as you've got good cerebral perfusion, you have to have that balanced out. Is what you're really targeted. So the take-home is decrease in cerebral perfusion due to decreased blood pressure or increased intracranial pressure equals cerebral ischemia. So that's what you want to avoid with these patients with intercerebral bleeds. Now again, back to assessment. We talked about level of consciousness, motor function, and this right here is pretty much your Glasgow Coma scale, okay, in a nutshell. Vital signs, you know, the respiratory being very sensitive, the PONS as far as to changes in pressure. Pupil size, okay, is important with this because as pressure increases, there's a shifting of contents within the brain, and that's when you're going to get the change in pupil as well as the size. Glasgow Coma scale decreasing. All this is related here. In addition to that, though, behavioral change may be the only thing you notice on your patient. So if they're increasingly agitated, irritable, or maybe just saying strange things, you may be checking them out for delirium, but the delirium actually may be increased intracranial pressure, and nausea, vomiting, and headache. This right here may be the only thing they present with at this time. So if they do this, you're just going to have to be responsible for doing a very thorough neuroassessment on this person to look for other things. They've got the nausea, and you may have Zofran ordered, that can be taken care of and given some of nausea, but don't let it stop there because very likely they could have an increased pressure because of that blood clot. And of course, if they seizure, that's a big deal too. So here is something we might see in the units in the future is called a pupillometry, where you can take a picture of the pupil and it will show the velocity and how quickly it constricts. Now this has been shown to pick up on increased intracranial pressure maybe several hours before what you can actually observe yourself with a pen light, okay? Because it shows the speed of constriction, okay, to light. And there's a lot of places use the pupillometry, so I don't know why we haven't got it here. I've sent several reps. I've told them to come talk to Erlanger to see if we couldn't get at least a demonstrator here to check this out. So to treat intracranial hypertension, what is the difference in that than a patient that has a traumatic brain injury and they've got swelling, edema, etc. So you're going to do all these things. Promote venous return, keep the head of the bed elevated, do not give them too much fluid, treat them with mannitol and sodium chloride 3% to take off the fluid, maintain their, treat their pain, sedate them as indicated, keep them normothermic, maintain their normal glucose level, maintain their gut decompression. This in a nutshell, we go into a lot more details, and you can look at trauma and their increased intracranial pressure guidelines for treating it. But this encompasses just kind of an outline of some of the things that is done for this when it occurs. Now, ICP monitoring, we put a monitor in here. This is an extraventricular drain. Serves two purposes. You not only measure ICP with these patients, but you can also remove cerebral spinal fluid, which is a very effective way of decreasing intracranial pressure. Now, here, as the clot expands for these patients that have these intercerebral bleed, it may get to the point where they have to take out a piece of the skull and allow the brain to expand. This is what Congressman Giffords had. This is what, there was a boy in trauma just recently that had bitemporal on both sides of the head. He had a piece of the skull removed. So that does happen. You knew him, don't you? Okay. I need to talk. Don't leave without me talking to you about him. Okay? All right. He's walking now. Okay? He was in an induced coma, what, for 2 weeks or something?
Oh,
more than that, really?
He's the first one I've ever saw survive on the Pupil.
Oh, really? Because really, okay. One of the last-ditch efforts when you have a real severe increased intracranial pressure is to induce the coma with pentobarbital. Now, this is like coming to the end of the road, last ditch, and saying, okay, everything else has failed, we're going to induce this coma. So they really weren't sure what was going to happen, were you?
Well, when they can't even donate for 21 days after they do that. You know, that takes everything out of the picture.
It alters their metabolism and everything, doesn't it? Well, anyway, this kid, 18 years old, wasn't he? Fell off the back of a truck and hit his head. He's walking now. I've got to hear more about that story. Okay, now, here the other 2 or 3 weeks ago, or maybe a month ago, we had a guy from the Apollo system that actually talked to us. But this is a probe that you can drill a hole and put this aspirator. It's penumbra. You know, we showed you the aspirating the clot out of a artery. This is to aspirate a clot out of the brain, okay? And Dr. Gallagher and some of the neuro folks are using this to remove clots, okay? So we're beginning to get ahead a little bit as far as intercerebral hemorrhage and clots and some treatments there. Okay, so when you're looking at Class 1 recommendations for these people with intercerebral bleeds, we see that you've got to reverse their bleed if at all possible. Like if they come in, they've got a warfarin, they've been on warfarin or Coumadin, you've got to reverse that if you can. You have to, they also, even though they bled, they're still going to be hyperthrombotic. I mean, they've had this clot form, and so you have to make sure that you have sequentials on, and at some point, they may even put them on low molecular weight heparin. Other things, incidentally, for y'all in ICU and in the emergency room, you may be using Kcentra to reverse the bleed. It's got several, actually 4 different vitamin K factors that can help reverse a bleed. I put this on here because it's on your order set, but you have to make sure you do an INR at baseline if you're going to give this, and then 30 minutes after the infusion, then every 4 hours. It's on there, but in the rush of things and everything, it's just good to have that pinpointed out to you. Here are other things as far as treating clinical seizures. Watch for change in mental status, prophylactic anti-seizure medication. Now, this is a level B recommendation. So, I mean, it's according to your neurologist, but the American Heart Association, their writings on this say it should not be used just as a general anti-prophylactic. Okay? Now, Jennifer, what's your take on that? Are you all...
For hemorrhage, it depends on where the bleed is. If the bleed is in the motor
Okay, it makes sense, doesn't it? Yeah. But otherwise, it's not like everybody that has a bleed gets an anti-seizure medicine. You know why? It alters your level of consciousness. It can make you mentally lethargic, some of these anti-seizure medicines. So if you can avoid a medication, it's a good deal. Cerebellar hemorrhage, expansion, or brainstem compression. It's suggested they have a clot removal, and now we got the aspirator thing they use that, I think, basically on the cerebral cortex. And what about the blood pressure? Too much blood, right? Ischemic was not enough. This is too much blood. So this is still the recommendations as far as I can find is 140 is probably safe. The studies really are not, as far as the research, it didn't come out with a definitive recommendation. So this is what they say, probably safe. And I think most of our docs, Jennifer, is that correct? 140, okay, based on this.